So this is a case of a 35-year-old female who presented to us with complaint of diminution of vision in the left eye for the past 2 years. She was diagnosed outside with left eye optic neuritis after CEMRI brain and orbits were suggestive of optic nerve enhancement. She received 3 doses of IVMP and followed by oral steroids for 11 days. And there was some improvement in the vision. But she presented again with a similar episode of diminution of vision after 14 months in the left eye. And again, she was diagnosed with left eye recurrent optic neuritis based on the CMRI, which again showed optic nerve enhancement. Again, she received 3 doses of IVMP followed by oral steroid. But the patient was not satisfied with the treatment, and so she came to RPC for second opinion. And when she presented to us, the vision was left eye 636 with an RAPD. The color vision and contrast were affected, and there was disc pallor on the fundus. So the next slide, sir. Yes, sir. The left eye had disc pallor. The next slide. So the RNFL OCT showed that in the left eye there was a superior and the temporal loss of RNFL, and in the ganglions in layer thickness, the next slide, sir, also showed a diffuse thinning of the GCIPL. Following the neuroimaging, we got an NRC review at our radiologic conference, where there was a suspicion of a left eye optic nerve glioma. So we again ordered a CMRI and a serial imaging of the 3 MRI films we evaluated, and it was found that the focal perineural thickening and enhancement in the posterior, intraorbital, and intracanalicular segment was seen. There was no change in the enhancement and the bulkiness in the serial imaging, and a remote possibility of meningioma was considered since there was no change. So these are the sequential imaging. This was the first MRI when she presented with left eye optic neuritis, the first episode in 2019 August. And we can see in the Excel section that in the posterior part of the optic nerve and in the intracoronal region, there is there's a bulkiness and also enhancement. Also in the sagittal section. In the next MRI, which was in November 2020, which we ordered, again the bulkiness and the enhancement is present in this in the axial and the coronal sections. We again revisited and we clinically examined the patient, and we saw that there is a left abaxial proptosis, which can be made out from the accentuated the lid crease, and also the proptosis, which is visible. So we ordered a NCCT orbit for her, and the NCCT orbit, we can see there is speckled calcification areas in the peripheral part of the optic nerve along with the thickening, and it was suggestive of a optic nerve sheath meningioma. So whenever we are reviewing a MRI or a neuroimaging and there is an optic nerve sheath enlargement, there are two possibilities, major possibilities, which come to our mind. One is inflammatory, the other is neoplastic. Inflammatory can be optic neuritis, orbital pseudotumor, and other recurrent optic neuritis as well. While in neoplastic cases, mostly consider optic nerve glioma, optic nerve meningioma, leukemias, and metastases. So what are the points which were in favor of optic neuritis in our case? She's a female, the age group fits, she's a 35-year-old female, and the color contrast are affected. There was an RAPD, there is a history of recurrence, there is a moderate response to steroid, and the CMRI orbits and the brain, they are suggestive of optic nerve enhancement. What are the points which are not in favor of optic neuritis? She presented with a painless diminution of vision. There was a mild proptosis. Sequential MRIs have shown thickening and peripheral enhancement, while the NMO and the MOG antibodies were negative. So optic nerve glioma, which was our second differential, first of all, it presents mostly in the first decade. There's a slow progressive diminution of vision. There is a proptosis, but the most important point was that it usually present in children and also can present with optic nerve head swelling. Also, the CT scan shows a fusiform enlargement with a clear-cut margin and intact dural sheath. While in our case, it was mostly there were the margins were not clear-cut and it was blurred. Now coming to optic nerve sheath meningioma, usually present in adult women in 4th to 5th decade. They are usually benign and grow circumferentially or around the optic nerve. There's a slow, progressive, painless diminution of vision, and they usually present with optic nerve atrophy as compared to optic nerve edema or swelling. Also, there can be signs of optociliary shunt. These are not true shunts. They are actually retinal drainage of the into the choroid. And CMRI shows a diffuse tubular homogeneous contrast enhancement, which can be in a pattern of tram track in axial section or can be a donut sign in case of a coronal section. And calcification can be seen in the CT scan, as we saw in our case where speckled calcifications were there. So to conclude, clinical history regarding the course of the disease and the response to treatment is important. Also, if we are suspecting optic neuritis, alternative diagnosis should also be considered. Subtle signs such as small proptosis, as in our case, should be evaluated, and NRC review of the sequential neuroimaging is important. And whenever in doubt, we can go ahead with CT scan. Thank you.
Thank you.
And
thank you, Dr. Priyanka.
Yeah, sorry for the glitch in the technical error. Sorry.
So essentially just bringing this case out to show that there can be a varied presentation of meningioma. In fact, meningioma is one of the most difficult things to diagnose and can present in a variety of ways, including presenting like a recurrent optic neuritis in this case. And meningiomas are known to respond slightly or moderately with steroids. So exactly that's what was happening. So there was a little progression, and she would get herself evaluated. They would give IVMP slightly better, and it was thought as if it's an MOG which shows sheath enhancement. So it's important to actually be in consultation with your radiologist and do very fine imaging and be sure that what is the imaging showing, rather than just rely on the report or just look at sections. Sometimes you may want to see the CD because the sections may not show you the exact appropriate images. So you may actually see the CD and see where is that tract going, or that thickening going, or the enhancement going, and see its detailed pattern. So, and of course we had the hindsight and we saw that we felt there was a little proptosis and all, and by the time she came to us, it was a much larger lesion that must have been there when she initially must have presented to the treating physician. So it's just that all of us should be aware that you can have a lot of other reasons for presenting like optic neuritis, and you should keep your eyes open.
Thank you, Dr. Rohit. Wonderful discussion.